Okay, good day, everyone. My name is Patrick McGowan, and I'm a professor at the University of Victoria, the Center on Aging. And the name of this webinar is Health Promotion, Chronic Conditions, and Self-Management Support. And my background is I have a doctorate degree in health promotion research at the University of British Columbia with Lawrence Green. And as well, for the last 25 years, I've been working in the area of self-management and self-management support. Initiating and evaluating programs in British Columbia and actually every province in Canada, as well as international endeavors. Okay. So what I'd like to do today is, first of all, introduce the concept of health promotion briefly, a little bit about its origins and its major elements. Secondly, I'll go over some really important considerations when you're dealing with chronic health conditions. Thirdly, to look at the limitations of evidence-based medicine and the potential role of self-management support and community health initiatives. And then lastly, I'd like to describe some self-management support strategies that healthcare professionals can use when you're interacting with patients. Okay, and these self-management support strategies address behavior. Okay. So, starting off with health promotion, I guess the first time we really became aware of health promotion in Canada was with the New Perspectives on Health of Canadians, and that appeared in 1974. And it was the first time, and this was known as the Lalonde Report. Okay, it was entitled A New Perspective on the Health of Canadians. And it was probably the first time in any industrial country that they realized that the health couldn't be attributed to physician services, hospital services, and pharmaceutical services. And that was really a breakthrough. And in the report, it identified 4 health fields that were independently responsible for individual health. Okay? Environment, human biology, lifestyle, and healthcare organization. Okay? Now, all of these elements, all these fields have a major role in bringing about health. But what I want to focus on today mostly is lifestyle, okay? The aggregation of personal decisions over which the individual has control. Okay? And that's going to be the focus today. So next, in the sort of ongoing history of health promotion in Canada, probably we saw the Ottawa Charter for Health Promotion in 1986. And this is where they actually came up with a really nice definition of health promotion. And that's the process of enabling people to increase control over and to be able to improve their health. Okay? And again, they identified 5 areas, 5 sort of strategies that would need to be taken for this to happen. Building healthy public policy, creating supportive environments, strengthening community actions, developing personal skills, and the reorientation of health services. Okay? But again, today, as I just mentioned in the last slide, we want to focus on developing personal skills. That means the information people have, the information and their skills to be able to do this. Okay? So, some really important considerations when we're dealing with chronic health conditions. First of all, people see clinicians only for a small fraction of the time. Okay? That means that the number of minutes that people interact with health professionals, people with chronic health conditions interacting with health professionals, is very, very limited when you consider a 10 to 15 minute interaction only so many times a year. There have been some studies looking at how much time this accounts for each year, and probably the most comprehensive study was conducted in Great Britain, where they concluded that on average, a person with a chronic health condition only interacts with health professionals for about 10 hours each year. So consider that 10 hours each year. So the implication of that is for 99.9% of the time, people are managing their chronic health condition by themselves. And it's only a small little percentage that they actually interact with some health professional. The second consideration is almost all outcomes are mediated through a person's own behavior. Okay? It's not what we tell people in the hospital or in the clinic or in the medical center that's going to make a difference. It's what people do after they leave the office, their behavior. A person is only going to get better if they follow advice on, for example, exercising or the way they eat or taking their medicines or smoking. Okay, it's not what we tell them, it's their own behavior. The third consideration is motivation is important, but it's not enough. Okay? Lots of times we put a lot of effort into motivating people, but people need the skills and the abilities to do it too. I mean, we're all motivated to do things, to get in better shape, to eat differently, to drink less and whatnot, but just doing it's a different story. And the last consideration is chronic conditions are really different from acute conditions. And most of the healthcare system that's been developed over the last couple hundred years have been based on acute conditions. And we just can't take all the premises and all the principles that we used in acute conditions to deal with chronic conditions. Chronic conditions are really different. Okay? Now, let's look at some of the limitations of evidence-based medicine. Okay? Now, what's evidence-based medicine? Well, that's, healthcare professionals using the best available evidence gained from the scientific method in medical decision making. Okay? And in some areas that's quite helpful, but in other areas, for instance, people with diabetes and hypertension who have to manage these conditions on their own mostly, a lot of people are still in poor control of it. Okay? And some of the limitations of evidence-based medicine, first of all, is the medical system isn't structured to assist people to incorporate these advances in their daily lives. And this, once people leave the clinic, leave the medical office, people have to be on their own. So this is where self-management will help. And secondly, people go out into the real world, okay? And the physical and social environment in which people live create major challenges for them, okay? Of course, people know that they have to eat vegetables and fresh fruit and eat a certain diet and fiber and whatnot, but if these things aren't available or there's no safe environment for people to exercise, and that's where environmental and legislative initiatives are needed. Okay. So we are focusing on behavior here because that's the whole intent of this webinar, to look at what the role of healthcare professionals, especially nurses, is to help people manage chronic health conditions. So let's look at behavior and lifestyle a little bit more specifically. Okay. This next slide shows the determinants of health and their contribution to premature death. And in this slide, you see that a person's own behavior is 40% responsible. And you compare that to the medical or the healthcare system, which is only 10% responsible. So you can see that a person's own behavior seems to be 4 times more responsible to premature death. Okay? So let's look at a really quite prevalent health promotion model, and this is called the Precede-Proceed health promotion planning model. Okay? And if you were to Google Precede-Proceed, you'd probably come up with, let's say, 2,000 articles where it's been used, published articles where this model has been used to help plan and evaluate healthcare initiatives. And what I want you to focus on in this model is that the box called behavior and lifestyle. So in this model, you start off from the right. You start off where it says quality of life, because that's the most important aspect of health, a person's quality of life. And you know that health is intricately connected to quality of life, and there's no dispute over that. A person's health is connected to the quality of health. But then we also see that a person's behavior and their lifestyle is connected to health as well. Okay? But behavior and lifestyle are complex phenomena. They're multifactorial, and they're influenced by these variables called predisposing variables, reinforcing factors, and enabling factors. Okay? And as well, a person's behavior and lifestyle is also influenced by the environment. So if you're going to take this model a little bit further, you could look on the right-hand side where it says health, and the person's behavior and lifestyle is connected to that. And in that predisposing character, you have things like a person's knowledge, their beliefs, their values about health, their attitudes towards health, and also their confidence in their ability they can do things. So those are really important factors to trying to address behavior. Underneath that box, you see the enabling factors, and that represents the health resources, the availability and accessibility, the laws, the priorities, and also a person's health-related skills. So even though a person may know what to do, they need the skills of how to do it. And then the bottom box has the reinforcing factors, because what we're talking about here is behavior. And behavior isn't a one-time flip-flop phenomena. Behavior is something you do over and over a long period of time. So what are the factors that facilitate or diminish this behavior from continuing? And family members and peers and teachers, employers, health providers, community leaders, and decision makers have an influence in facilitating the continuity of that behavior. Now, in addition to predisposing, enabling, and reinforcing factors, you also have environmental factors. And that's what I mentioned just a few minutes ago about, well, if a person wants to be able to go for a walk, there has to be a safe place for them to be able to go walking, where they're not afraid they're going to be mugged or something. Okay. Now, in British Columbia, as well as most provinces, and especially Ontario, you have your chronic care model. Okay. And the outcomes of our chronic care model is we want to have informed, activated patients interacting with prepared, proactive practice team members. Okay, so this is where we fit in. We're the prepared, proactive team members, and what we can do is we can use self-management support strategies to enhance this interaction, and when that happens, functional and clinical outcomes are better. They're more effective and they're improved. Okay. So this is the definition of self-management that seems to be the one accepted mostly across Canada. Okay. The tasks that individuals have to undertake to live well with one or more chronic conditions, and these tasks include having the confidence to deal with medical management, okay, role management, and emotion management of the condition. So notice in that definition, the person's doing something. Okay, they're doing something, they're not just sort of aware of it, but they have confidence to deal with medical management, so all the things we need to be able to work with health professionals with. Role management, that's our role as a father, a breadwinner, a member of a team, and also emotional management of the condition. Okay, but what's important here is this is what the person with the chronic health condition engages in, not healthcare professionals. Okay, this is what this definition right here, self-management support, is what healthcare professionals do. Okay, and this is where we provide education and some other types of supportive interventions to increase the person's skills and confidence in managing their health problems, and that includes regular assessment and progress and problems, goal setting, and problem-solving support. Now notice that this definition of self-managed support is a little bit different from the traditional definition of patient education. In patient education, we used to provide people with information about their disease and also with some skills that they could use to manage when things went wrong, sort of for contingency planning. But in this definition, you notice it's interventions that raise their confidence to manage health problems, and includes regular assessment. And notice these concepts of problem solving and goal setting. Okay, so let's look at this concept of self-management support a little bit more. Like, is it an intervention or is it an outcome? And in the literature, you see it used both ways. Okay. Now, you look more succinctly at it and ask yourself, is it an independent variable or a dependent variable? Like an independent variable is something that, like it's an intervention, is what we do. And across Canada now, it's considered as an independent variable, and it's being implemented by strategies used by healthcare professionals, and it's also being implemented by those community self-management programs that are available in most provinces. Okay. If we do ever consider self-management as a dependent variable, that's the outcome, then we would speak of patients having the skills and the attitudes and the behaviors needed to manage chronic health conditions. But what I'd like to propose here, it only makes sense for us to use it in terms of an independent variable, because that's what we're talking about. We're looking at an intervention, strategies that we can use with patients to make them more empowered. Okay? Now, this is the way that self-management seems to work, and this is the sort of the flow, the causal chart, the causal chain that the RAND Corporation completed in their major evaluation of self-management in 2007. So self-management interventions is used, and patients' confidence increases, and also their skills, their knowledge and skills increase. And then when that happens, the patient's behavior changes a bit, and when the patient's behavior changes, the behavior of healthcare professionals change a bit as well. And when that happens, it leads to disease control, and when disease control takes place, it leads to better health outcomes and less healthcare utilization, and that leads to increased patient satisfaction, and then that addresses costs. Okay? That seems to be the causal chain of how it works. Okay? Now, we do have quite a good document developed by the Registered Nurses Association of Ontario, developed in September 2010, and that's entitled "The Strategies to Support Self-Management in Chronic Condition, Collaboration with Patients." And this was a document that they spent a couple of years preparing, where they took all the best evidence possible to come up with what strategies produce the biggest bang, the biggest impact. Okay? Now, when you look at all the different strategies that possibly can be used to provide self-management, you have the 5 A's approach, which seems to be one of the most popular. You hear about people saying they want to use motivational interviewing. Okay, that's another approach. Then there's an Australian program called the Flinders model, the Flinders program, which is quite labor-intensive, and I know it's used in Australia, but we really haven't used it very much in Canada. Okay. There's a program called Choices and Changes that is becoming quite popular. There's another one called 3-Minute Empowerment. There's one called Q Questions Interview. There's even been a Stages of Change intervention developed, and then health coaching. Okay, so those are all the possible sort of programs that you can use to get healthcare professionals to use self-management support strategies. Okay. The one that's most popular is called the 5 A's, and this is the one on which the Ontario Registered Nurses Association document is based. And the 5 A's stand for assess, advise, agree, assist, and arrange. Now, the 5 A's is based on the 4 A's, okay, and it used to be used in alcohol and addictions counseling, but Canada actually contributed an A, made it 5 A's. So we would all think that because we're Canadians, probably it's agreed that Canada contributed, but it isn't. It's advise. And this 5 A's is a construct. Okay, each of these 5 A's has 2 or 3 strategies in it, and they're used when you only are able to interact with the patient for a short period of time, like 10 to 20 minutes, and also when you're interested in getting a behavior change. Okay, a behavior modification, either for the patient to start a behavior, modify behavior, or change a behavior, or diminish behavior. You want the patient to start exercising, for instance, or to change the way they eat, or to stop smoking or something. Okay, it's to use when you're interested in affecting a behavior. Okay? Now, as I mentioned, the Registered Nurses Association of Ontario developed these guidelines, and they're based on the best information available, and the panel that was involved reviewed all the literature in the world and came up with sort of a rating system to say how strong that evidence is. And anyone can go to the website on the bottom of this slide here and download it for free. Okay, and there's no cost to that. Okay, and this is the sort of the evidence scheme that they used. Okay, first of all, in the world, the strongest evidence is considered evidence obtained from meta-analysis or systematic reviews of randomized control trials. Okay, no matter what, even though there's lots of argument against it, that's the considered best type of evidence, strongest evidence. Okay, under that, evidence, but not as strong, is evidence obtained from at least one randomized control trial. Okay, and then 2A is evidence obtained from at least one well-designed controlled study without randomization. 2B is evidence obtained from at least one other type of well-designed quasi-experimental study without randomization. Number 3 level of evidence is evidence obtained from well-designed, non-experimental descriptive studies such as comparative studies, correlation studies, or case studies. And then level 4 is evidence obtained from expert committee reports or opinions and or clinical experiences of respected authorities. Now notice here that it's all evidence. Okay, and in medicine and in healthcare, sometimes we only have level of evidence up to, let's say, 2B. Okay, and even sometimes level 4. But the point is that some evidence is stronger than other evidence. Okay, so in the nursing document, the registered nursing document, you'll see something like, here's a recommendation. Nurses should collaborate with patients or clients to establish goals, develop an action plan that enable the achievement of the goals, and monitor progress towards that goal. And that's level of evidence 1A. So the strongest evidence supports that. Okay. Secondly, nurses who are appropriately trained to use motivational interview can do that. And again, 1A. But notice here it says appropriately trained. Okay. Again, number 3, still in the assist category. Nurses should teach and assist clients to use problem-solving techniques. 1A again. Okay. So through that whole document, you'll see these recommendations of these strategies that are part of the 5A strategies, and it'll show you how strong that evidence is. Okay. So let's just look at a few of these techniques a little bit more succinctly now. Okay. Teaching people to problem solve. Because people have to problem solve on a daily basis. Remember that first slide I showed you that people only spend a fraction of the time interacting with health professionals? So health professionals don't solve problems for patients or for people with chronic health conditions. People have to do that themselves. So this is a problem-solving process that healthcare professionals can teach patients to use. Okay? You don't solve the problem for your patient or your client. You teach them a problem-solving process so that they can solve problems on an ongoing basis. And this 7-step process isn't rocket science, but it is rocket science. It has been really well tested over time, and a few steps are involved. Identifying the problem very clearly, okay, coming up with ideas that could solve the problem, and select one to try. And then you assess the results. If it doesn't work, substitute another idea. Okay. If you can't solve the problem yourself, you go to number 6, you utilize other resources. That's where you ask others for help. And then finally, 7, if you still can't solve the problem, you accept that the problem may not be solvable right now, but again, you try it again in 2 or 3 weeks, and at that time, maybe you see the problem in a different light. People still use this, like when people learn this technique, they use it over and over and over in their life because it seems to work. And again, there's strong evidence, 1A, that this technique is effective. Okay. The second one that was really, really effective, 1A, is where it says nurses should collaborate with patients to come up with goals and action plans. And a goal would be something like, well, I know I need to start walking and exercising, so maybe 6 months I should be exercising on a regular basis. So then what you do as a health professional, say, well, let's look at this week, okay? What's something that you'd like to do this week to work towards achieving that goal? So I'll say this week I want to go for a walk 3 times. Okay, so you have to guide the patient and say, is that something you really want to do? Say yes. Is it reasonable? Yes. It's behavior specific, and it's so clear that answer the question, what are you going to do? Well, go for a walk 3 times. How much 3 times? When? I'm going to do it in the afternoons, like 1 to 2 or something. How often? I'm going to do it 3 times. And then lastly, Number 5, you say, on a scale of 0 to 10, how confident are you that you're going to actually do what you just said? And the person has to say 7, 8, 9, or 10 out of 10, because that's where the self-efficacy theory comes in. Okay? The theory says the more confident a person is that they'll do something, the greater probability that they will do it. So if they say 7, 8, 9, 10, there's strong probability they will do it. If a person says 2 or 3 or 4, then there's strong probability they won't do it. In that case, you have to say, what seems to be the problem of you accomplishing that goal? And sometimes health professionals actually use a written form. Here's something that you and the patient can work together with. On the top it says, here's the review of the parts of the action plan. So it says, my action plan this week is, I will go for a walk 3 times. My confidence level is 7 out of 10. And then I'll sign it, and then healthcare professional will sign it. Sometimes it seems more official and a little bit more commitment if the patient signs and the healthcare professional signs it, but I have to say that there's really no evidence in the world that says it works more if you sign it or you don't sign it. Okay. So here's another technique now. It's trying to figure out how ready a client is to make a change. And what you do is you zero in on a particular behavior. Let's use a behavior of I want to start walking. I know I have to walk. I have type 2 diabetes, and I'm overweight, and I know I have to exercise. So you say, well, how important is this to you for you to start walking? And I'll say, oh, it's really, really important. Okay. And then you ask, well, how confident are you can walk? If you wanted to walk, how confident are you can actually do that? And I say, oh, it's really, really important. Okay. So you ask 2 things. How important is this behavior to you, and how confident are you? And then the result you'll get looks something like this. There's 4 possibilities. Okay, again, it's either important or not important. It's either the person has confidence or they don't have any confidence. And what you would like is you'd like the person to be in this box, which I've just put a B on. Okay, because again, a person, whether they're going to carry the behavior, depends how ready they are to do that, and readiness depends how important they think that behavior is and how confident they think they can do it, that they can do it. So when a person does answer that yes, the behavior is important and I have confidence, then they'll be in box B. And what you do there is you just say, wow, that's fantastic. That's really, really good. Again, you're noting and you're affirming the progress. You help them plan for relapse. Okay, Patrick, you're going to go walking now, but it's getting really icy and snowy on the road. Where are you going to walk? So you help them decide an alternative place to walk. Plan for relapse, and help them remove any obstacle that might get in the way of them continuing it. So that's where you want patients to be, but not all the time you'll have a patient who's in that mindset. Okay. You want them in that box because the greater probability they'll actually do it. Usually a person will be in box A. Okay. Yes, I know it's important, but I can't. I don't know how to start. That's where you make the small action plan. Okay, that's the most important strategy there. Also, you can ask them how they made hard choices in the past or how they resolved difficult situations in the past. But the best strategy there would be to help say, let's make a small action plan then this week to get started. Okay, it's possible that a person might answer in this category I call the C box here. No, it's not important, and no, I can't. Okay, you have to sort of be cautious with this box because maybe something else is happening in that person's life right now. Maybe there's some other things happening with other family members and they're just in the wrong space for it. Or they could be depressed as well. And if they are depressed, you get the depression dealt with. Okay, you make your protocols and your processes and your referrals. Okay, but if a person says, no, it's not important to me and I can't, then you just accept that. And you keep the door open and you say, well, when do you think you might want to talk about this, or let's talk about it next time? Or sometimes even just one piece of paper, a tiny bit of health information. Say, can you take this and maybe we'll talk about it next time? Okay. So that's sometimes the case. And then there's this last category, we'll call it the D box. And this is known as the male box because more males seem to be in this box than females. And they say, I can do it if I want, but it's not important. But if I wanted to, I could. And that's where you have to say, well, let's look at let's look at some of the discrepancies, okay? So the person will say, well, look, you tell me that I should go walking because I have type 2 diabetes, but I just read this major Health Canada report. It was on the internet, published by Health Canada, and it said all the people who participated in this project didn't lose any weight at all. So what do you tell me? I should go walk and lose weight? So you have to say, well, no, there's other things that happen when you exercise, when you have type 2 diabetes. So you have to explain to the person so that they can get the right idea. Okay, so that's one strategy you use. The second strategy is to explore the pros and cons of that particular behavior with that client, which I'll get to in just a second. And the third thing you can do is discuss their hierarchy of values. You can say, Patrick, you've been coming to see me as your doctor or my nurse for the last 15 years, and you tell me about your grandson, how he loves fly fishing, and you have a fantasy about when he's turned 16 years old, you're going to take him fly fishing along the side of the Fraser River to catch the big salmon that come in, and you're looking forward to that. Well, Patrick, how are you going to do this in the condition that you're in? Look at your diabetes now. Okay, that's not a scare tactic strategy. That's getting the person to reassess their hierarchy of values, and lots of time that's enough to get Patrick to start exercising. Okay, but let's look at exploring pros and cons. Okay, so when a person is ambivalent about making a change, they can do it if they want, but they don't think it's important. The strategy that we've commonly used in the past is we tell them all the bad things about the current behavior and the good things that might happen if they change. Example, if you continue not to exercise, you're probably going to have circulation problems and maybe even amputation or heart problems. But if you change your behavior and start exercising, you get a lot better. Okay. What happens when you do that is people start defending their current behavior. They'll say, I feel fine. I like my life the way it is now, and it's not that bad. At least I don't smoke. And they start providing reasons for not changing. Like, I don't have the time. It's going to cost money. I don't have any place to exercise. And also, I'm embarrassed about my shape. So using that technique of telling them all the bad things about the current behavior and the good things that will happen if they change doesn't work. It backfires. So one technique you can use is this technique looking at the pros and cons. So what you do is you become the scribe. You say, Patrick, let's talk about the current behavior. You have type 2 diabetes and you're not doing any exercising, and we're talking about walking here. So, Patrick, what are some of the good aspects of this current situation? Okay, and you let the patient talk. You don't provide this. You ask the patient for these things. So the patient might say, well, I don't know, aggravate my condition, and I don't have any hassle of exercising, and I can deal with a little bit extra pain. It's not that bad. I can take medicine, and it's warm and cozy at home now. So you say, okay, is that all the good aspects of the situation? Yeah. Okay, now let's look at some of the not so good aspects of this situation of you having type 2 diabetes and not exercising. So what are some of the not so good aspects? And the person might say, well, I'm feeling weaker and weaker all the time, and I'm feeling tired, and I feel old, and I can't move like I used to, and I have trouble playing with the grandkids, and I'm actually afraid I'm going to lose my ability to walk, and I have trouble sleeping at night, and I keep gaining weight, and my clothes don't fit, and I'm getting embarrassed by my shape. So notice here that as a healthcare professional, you didn't stimulate these responses, you didn't add them, you let the client. And when the client looks at the whole picture together, the good aspects and the not so good aspects, then the client will see that the not so good aspects seem to outweigh the good aspects. And this is a good strategy to get a person to actually start in this behavior. Okay. Now I want to sort of reconfirm that this is for when a person says, I can do it if I want, but I don't think it's important. So you can use this strategy to address a person smoking. Like you have lung disease, Patrick, and you're still smoking. What are some of the good aspects or not so good aspects? Or in it taking a certain medication. Okay? So here are some other strategies that you can use that are part of that Registered Nurses Association of Ontario document when they look at the 5 A's. This technique right now is called establishing the agenda. Okay? And it's, good morning, Mary. We have 15 minutes together today. I need to speak to you about your medicine. what would you like to speak to me about? Okay. That technique is called establishing the agenda because it lets both the client and you make it really clear what you're going to talk about. It gives you both a chance. Okay. Notice it sets the boundaries right away. We have 15 minutes today, and then you model. You go first and say, I need to speak to you about your medicine. What would you like to speak to me about? And lots of times you can even sort of give a sheet of paper to the person while they're waiting in the waiting room to see you, asking them to think about what they want to talk to you about today. And in this case, you have diabetes. Here's some of the things you can talk about. What would you want to talk about? So you have some suggestions already inside these circles, but you leave some vacant circles as well, so a person can put the thing that they're most interested in talking about. Okay? So lots of times people don't have a chance to talk about the most important thing, and this does give the opportunity for both the healthcare providers and the patient's most important need to be addressed. Here's another technique called establishing a rapport. Okay, you use open-ended questions. An example would be, tell me about a typical day. Last Tuesday, Mary, tell me what happened on Tuesday. Okay, or you use this technique called what else is happening. Okay, so I'll demonstrate this, what else is happening. Okay, here's version 1. Oh, good morning, Mary. What brings you here today? And Mary says, oh, I have headaches. Oh, headaches, eh? So, Mary, show me where are the headaches now? And you examine that. And when you get the headaches, how long do they last? And you start exploring that. And what have you been doing to relieve them? Okay, so you've really sort of gone down the path of examining Mary's headaches. But here's the same person. Okay, so hello, Mary. What brings you here today? Oh, I have headaches. Or what else? Well, I'm having problems sleeping. Anything else happen in your life? Yeah, I'm really worried about my son. He's using drugs. And notice this is the same patient, okay? But in the first instance, we went down one road, and now we're going down a different road. And version number 2 is the valid road here. Okay? Lots of times we don't give a person an opportunity to see what's really the most important thing. And you can't address the headaches until you get to the most important thing. And sometimes you have to ask, what else is happening, up to 5 times. Now, people might say, oh no, this is like opening a can of worms, it's going to go on. But it doesn't. It only takes a couple of minutes. And you're only going to be able to address the most important, the health problems, if you address the most important that's on Mary's mind right now. Okay? So this technique is called establishing rapport with patients. Okay? Now, other self-management strategies that have good levels of evidence, for instance, levels 3 and 1B, is ask, tell, ask. That's another technique. You are very specific with the patient. Tell me, Mary, what do you want to know? So Mary says, well, I want to know what I have to do, blah, 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 blah. So then you give the information, and you say, okay, good. What else do you want to know? Okay, just that one technique. Okay. It sounds like a simple little technique, but there's lots of validation, lots of research behind that. Second technique, closing a loop. And this is where you say, boy, I've said a lot of information today, Mary. I've given you a lot of information. Just to make sure that I've covered everything, can you repeat back to me in your own words so I make sure that I've covered everything? And this is where Mary will tell you back what she's heard. And this gives you a valid opportunity to make sure that Mary's understood the information and you explained it properly. Because in reality, up to half the patients leaving the office have the wrong information. And, if people are only going to see healthcare providers a certain number of times each year, it's really important for them to get the right information when they do. Okay, if your patient is depressed, don't even bother trying to use self-management support strategies. Deal with the depression. In your setting, you must have some protocols or some process or referrals. Okay? And another technique is make a referral to a self-management program if there's some in the community. Okay? What the Health Council of Canada says now is that only about 25% of patients with chronic healthcare conditions are told by healthcare professionals that they should take self-management programs. Okay? But when a healthcare professional tells a patient that they should take a self-management program in the community, the probability of them taking it increases 18-fold. That means 18 times to 1 that they'll actually do it if you recommend it. So all you have to do is say, look, there's some really neat programs in the community. Why don't you take one? I think it'd be a good idea for you. Then come and tell me about it. So here's a sort of a schema showing that all these techniques in one picture. And the goal here is you want your patient to have a personal action plan. Okay, and that's where they have their goal and action plan in there. They'll know what the barriers are. There'll be a little plan how to follow up, and they can share this with other members. And you use those techniques that I just mentioned that fall into the categories of the 5 A's: arrange, assess, advise, agree, and assist, interactively. And you don't have to use one technique in any sequence. Slip one in when you're able to, because even if you slip one in, you'll be more effective. If you slip two, you'll even be more effective. The more you use, the more effective you'll be. Okay? So now let's just review quickly the 5A approach. Okay? And these are little techniques that you can use that follow in the 5 A's. Number one is get a person to do one of those health risk appraisals at home. They can go online. Example is My Health. These are little interactive health risk appraisals people can access on their websites. Get them to do it. They complete it. And when they get the feedback, they bring that in and share it with you, and you can talk about it. Okay. The second technique I told you about is assessing how ready a person is to make a change by asking them how important the behavior is and how confident. The reason why you do this is to tell you what strategy to use. Because if a patient thinks a healthcare behavior is really important, that they should be exercising, there's no use for you to give them a lecture how important it is anymore. You'll just turn them off. They already know that. If they really, really are aware that it's important, then all you've got to do is focus on a small action plan to get them to do it. Okay? Setting a visit agenda, okay, that ensures that both the healthcare professionals and the patient's concerns are addressed in the visit. Establishing a report ensures that the patients have opportunities to express their priority concerns. Okay, teaching them how to make action plans, help them to start and to maintain a behavior. Okay, this is so important. I mean, people are overwhelmed when they leave a doctor's office or a clinic. They're told that they have type 2 diabetes and a bit of hypertension and maybe a bit of osteoarthritis. So just as they're leaving the office, they said, oh yeah, you got to, before you leave, you have to change the way you eat, you have to start exercising, you have to stop smoking, and take yourself to the Diabetes Education Center. And you can understand those simple instructions that just rolled off someone's tongue, but how do you actually get started? People are overwhelmed. Change the way you eat. How do you change the way you eat? You're 50 years old, you've been eating a certain way for the last number of years. How do you do that? Okay. Using those action plan is a way of getting started. Okay. And again, the problem-solving process, really important because people manage by themselves. Okay. Follow-up. Number 6, follow-up. When people make action plans, you've got to follow up with that some way. Either get the person to phone you, email you, leave you a message about that action plan. If you get a patient to make an action plan and you don't follow up, the process is null and void. It doesn't work. There has to be a follow-up, some opportunity for the patient to call you or someone in your office to say, here was my action plan and here's how I made out. Okay, then there's that ask, tell, ask strategy that I mentioned, and also closing the loop about ensuring that the patient has the right information. Now, we talked a little bit about motivational interviewing, but not very much. And although I'll acknowledge that motivational interviewing might be a powerful tool if you're trained and you have the support in your facility. Okay. Now, in 2010, Milner and Rolnick, who are the authors of motivational interviewing, had to come up with a special article because motivational interviewing was being described in all different ways that they never intended. So they really made it clear in that 2010 article that motivational interviewing is collaborative and patient-centered. It's intended to enhance a client's motivation to change talk, and doesn't need to be based on the stages of change. Okay? It's always meant to honor the patient's autonomy and should never be used to coerce them to do what you think. So if a patient doesn't want to stop smoking or doesn't want to change the way they eat or exercise, then you shouldn't use it. It's a complex clinical skill that requires practice to increase proficiency. It's not a step-by-step use in manual. Okay, and it's a method to elicit solutions from the client rather than providing the client with the answers. And it's not necessary if the person's ready to make the change. Okay, so just a little caution about motivational interviewing. Now, another technique that's becoming quite popular is these things called group visits, where, let's say, 10 people meet with a healthcare professional for a 2-hour period. And in this period, during the first 20 minutes, you can, with the group, establish the agenda using that technique that I already described. Then you can do a little information or educational session that's appropriate to everyone. Then you deal with each patient's priority problem one by one. And when you're doing that, everybody listens, everybody participates, because this is where vicarious learning takes place. And in that, you do brainstorming with the rest of the group and problem solving. And then at the end, each patient makes an action plan from the period this period until the next time they're going to meet. And each person sort of appoints one of the other people to be their sort of buddy to follow up on the action plan. And one of our health regions in the province actually spent quite a lot of time coming up with some guidelines for group visits. And if you go to the websites on the bottom here, you'll have a nice document that sort of talks about all the little principles. Okay, so back to evidence-based medicine. Okay, we talked about evidence-based medicine and how it wasn't by itself sufficient to bring about evidence-based health. So what the new formula should be is evidence-based medicine. We still want healthcare professionals to be using evidence-based medicine, but then when they leave the clinic, people have to learn self-management support, the strategies. Okay, and also, on the bigger picture, we have to have community health initiatives. We have to help people in providing of some fresh markets or places where they can buy the foods that they should be eating, a place to exercise, and that's where municipalities and other levels of government are involved. And if we achieve that, then in the end we have evidence-based health. But today's webinar is mostly based on self-management support. Okay, and that's where I'd like to end. Okay, again, here's my contact information, and our website is on the bottom. So that's where I'd like to conclude this webinar.